Hello, hello. So I think we are ready to. Is that right for our support? Yes, okay. Well, good afternoon, everyone, and welcome. Thank you for attending this day three activity for the national launch of diabeteshealthequity.org. This project is made possible through a partnership between the National Center for Primary Care at Morehouse School of Medicine and the Bristol-Myer Squibb Together on Diabetes Initiative. That's the Bristol-Myer Squibb Foundation Together on Diabetes Initiative. I am Sabrina Jackson, and I have the distinct privilege of leading up the Morehouse side of this partnership. I will serve as today's moderator and would like to extend a very heartfelt welcome to you all who've come to join us for today's panel discussion. Before we begin, I'd like to take just a few moments to sort of frame today's conversation, but as well as this project. In any given community, we have what we call three elements. As you see on your screen, there's clinic, where we believe people in any given community are working to give best practice care to the people who need it the most. In that same community, you may also have community organizations who are providing some kind of support to those same people. And then there are what we call the data collectors, or those folk who are in charge of the outcomes. These may be hospitals or even insurers who are collecting information about outcomes, whether or not people are having amputations, how many times they're in and out of the hospital. But what we found is that many people are operating in silos, so they're not working collaboratively. So our solution to decreasing the disparities that currently exist is to not only ask the question, but take on the challenge of how do we tie them all together? Our idea is to tie them all together to somehow facilitate a way that they can all work together in a rapid cycle improvement process, believing that when these three elements work together in tandem, we get better outcomes and therefore decrease the current disparities that exist in vulnerable populations. So, with all of that said, today's topic is care coordination, a virtual site visit to the three element model, and we will focus on the Institute for Family Health. Our distinguished panelists are Dr. Verna Little. Dr. Little is the Vice President of Psychosocial Services and Community Affairs at the Institute for Family Health, and she's responsible for the administration and delivery of behavioral health, community, and grant-funded programs in 26 FQHCs throughout New York City and the Hudson Valley region. She's also responsible for the administration and clinical oversight for almost 200 staff members and is nationally and internationally known specialist in the integration of behavioral health services. Dr. Little has extensive experience providing behavioral health services in healthcare settings, as well as developing and operating community programs. Before joining the Institute, she provided social services at the Department of Corrections and was a domestic violence coordinator. She has her doctoral degree in psychology along with a master's degree in social work and holds a bachelor degree in both psychology and social work. We also have Christina McGough. She's a registered dietitian, a certified diabetes educator at the Institute. Her roles include promotion and implementation of diabetes program services in the Bronx and Manhattan, supervising diabetes care managers to identify and target diabetes patients at highest risk for developing complications, and providing individual and group education to patients living with or at risk for developing diabetes. Before I bring on the panel, I have just a few housekeeping items. We have planned an engaging dialogue with two real-world experts, and you will have the opportunity to interact with them at the end of the presentation. So please, while they're speaking, jot down your questions, but hold them until the time when you'll be directed to type them into the Q&A box at the bottom right of your screen. So, without further ado, ladies and gentlemen, please help me welcome Dr. Verna Little and Christine McGough.
When the institute was started, my hope was that we would engage in the construction and development of new community sites in underserved communities, that we would train family physicians and other health personnel to be able to staff the
Hello? Yeah.
the sites, and also that we would be engaged in health services research so we
Okay, that's fine. Hmm.
the institute started, my hope was that we engage in the construction and development of community sites in underserved communities, that we would train family physicians and other health personnel to be able to staff those sites, and also that we would be engaged in health services research so we could help to move the state of the art and the state of the science of primary care forward.
So the challenges are that many patients don't understand what diabetes is. And they don't understand how it affects their body. And how it actually is a disease that can be controlled. If proper care is taken in regards to their diet, exercise, and utilization of our support services.
So one of our main areas of research and trying to improve quality has been around looking at healthcare disparities. So you think about healthcare disparities, oftentimes people think, well, this is something that you can just kind of fix on a job for people when they come to your health centers. but you know, it's been proven widely across the country that that doesn't really reduce healthcare disparities. In general, the story of healthcare care disparities in the United States is everybody's healthcare is getting better, but the gap between people of color and whites has not really been diminishing.
So a lot of our patients actually have diabetes.
We apologize that we are having some technical difficulties with that video. We can go ahead and just get started with our presentation. That really was the majority of the video. What our intention was is to give you an idea and an overview.
Okay, I just want to make sure that everybody can hear me. I've had a little bit of technical difficulties here. Great. Okay, I will try to do that. Sorry, we've had some significant difficulties here. Is that a little bit better? Okay, I'm going to assume that's a little bit better. Thank you so much that was a wonderful video, and thank you so much for allowing us to share time with everybody today. I want to just give you a little introduction on the Institute for Family Health. You just saw some words from our president and CEO, Dr. Kalman. So the Institute is the largest federally qualified health center network in New York. We've been around since the early 1980s. And we have been working really hard developing our diabetes and our chronic illness programs. We have had a commitment to the communities that we serve in our 26 federally qualified health centers. And one of the things that we've done is we really work with the communities and have the communities come to us around building one of our health centers. And what that's done is really allow us to develop some strong community partnerships, particularly around our diabetes care. We've also worked hard to develop becoming an NCQ level 3 in a primary care medical home. And I think what all of those initiatives have done is really helped us to come together and to think about the care that we're providing and to think about how we're delivering diabetes care and to really try different things in our center, some of which Christina will probably touch on as we go forward. And one of the biggest decisions that we made about 12 years ago was to really go forward and implement an electronic health record system, which we have been on for about 12 years. And over the course of time, we've really been able to collaborate with other organizations around the country and with our community partners and really design our system around delivering care to our diabetics. So one of the things we did several years ago is really put some resources into developing a diabetes registry, which has been helpful both from a population level and looking at our population of diabetics, but also to help our individual providers manage the care of our diabetics, to build decision supports in conjunction with the diabetes care team that's going to, will be helpful for our providers, to develop our patient portal so that our patients with diabetes can access care and information in a feature called My Chart, the patient portal, that really gives them a link to information on medications and diagnoses, both in English and Spanish, allows them to communicate with their provider, to change appointments, and I think that's been incredibly helpful. One other piece that we did is really capitalize on the physician portal in our electronic health record and really involve community-based organizations in the care of our diabetic patients. We have over 100 community organizations that have access to our electronic health records, and what that does is allows them to be able to help patients schedule appointments in the, from the community, and also be able to see information on the patients that we care for together. As an example, a patient might be referred to a food pantry, they would be able to go in with the patient's consent, see their diagnosis, see that they had diabetes, and then really work with them to select food and to put together a menu that might be helpful for them. So those are some of the initiatives that we've worked on over the past couple of years, across the Institute and involving some of the community-based organizations. And as we go forward, what we're hoping to do is in our practices continue to develop the use of teams and creating transdisciplinary care teams to really think about addressing the needs of the patients coming in that day and having some case conferences and discussions, being able to connect with patients the day before they come into their provider and be able to do some pre-visit work. So I think we're continuing to think about how to best, utilize teams in the practice, but also how to really develop care, accountable care for our diabetic patients, particularly in the area of ACOs. We have developed an ACO, and so a large part of the ACO population is diabetic, and really thinking how are we going to be accountable to these patients and how are we going to really engage them and track them in care. And so hopefully over the next couple of years we'll be able to figure out some ways and hopefully improve on the care that we're doing now. And so what I'd like to do is turn it over to Christina, who is in the thick of the care for our diabetes patients in our practices. Go ahead, Christina.
Thanks, Verna. Can everyone hear me?
Yes.
Okay, wonderful. So as Verna says, I think the two things that I have been most instrumental in our diabetes care as a really qualified health center have been our electronic medical record as well as our diabetes registry. We have over 8,000 patients with diabetes in our network, and we expand from the Mid-Hudson, which is a more rural community in New York City, to a very urban community in our New York City area. And so across our expanse of coverage, there are different needs for different patients. And I think having an EMR tool that allows us to communicate across sites, irrespective of how many miles are between us in terms of coordinating care and standardizing our efforts has been immensely helpful. Our registry allows us to figure out and prioritize the care that our patients need. As Dr. Kalman points out in the video, not every patient with diabetes has the same level of need. And what we have found is that our underserved minority populations come into us sicker, and so we end up having to put in more care when they enter our doors to figure out what are those barriers to care. And to assess that, we have questionnaires that individuals that we've coined diabetes health coaches do to assess patients coming into us to see where they are with their self-care. A lot of chronic illness is about self-management, and so we needed to identify ways to standardize our approach to figure out what is it that our patients need and how can we leverage the resources not only that we have in-house in our clinics, but also connect them to their communities and services in their communities with a lot of co-collaboration with our psychosocial services department. And our EMR allows us, again, to communicate, share a chart of a patient between a social worker and a provider, and we can actually dialogue and have patient discussion about what happens next, or hey, this patient is coming in to see you next week. This is what we discussed. Please take a look at my note. And we really try to optimize our use and communication using our EMR. The registry affords us to see where are our sickest patients at any given site, and then we try to coordinate our site teams to communicate with the patient when they're coming in, or outreach the patient to come in, and then the day of the appointment really communicate with the patient about what our role is in their care and that we're there to help them better take care of themselves. And I think having the in-clinic supports helps patients not only realize that there's a lot that needs to go on into their self-care, but if they're going to be at the clinic for some time, that we're working to make sure that they have the correct medication or that they understand why they need to start insulin. So it's dialogue between the patient and their care providers, and they may not be used to that level of dialogue. And so as Verna was saying, we really can look at the chart before they come in and say, hey, this patient needs these 5 things. They need to have their urine checked. They need to have an A1C to assess their blood sugar control. And we know those things before they come in by looking at our registry and then reviewing our schedules and doing some pre-visit work. And so, I can continue to give some examples, but I think really learning from what has worked within our EMR and optimizing and enhancing our best practice alerts so that a provider doesn't have to think on the fly, what is it that this patient needs right now? The best practice alerts are basically enabled if a patient is due for something. And so it takes the guesswork out of what the patient needs for their quality diabetes care. And that's a standard across our sites and across any patient that has diabetes. And we also have best practice alerts for other health conditions, but that really has enabled us to meet many of our quality care metrics. And it also allows patients to know more about the kinds of measures that we're monitoring so that we can assess how well their health is. And patients then become familiarized with their blood pressure levels, or with what the A1C means, or with what an actual glucose level should be, because we're doing them so regularly and we're dialoguing with them about it very frequently.
I have a question. And for the audience, if you do have questions as we go through this discussion, then feel free to go ahead and submit them. Well, actually, I have lots of questions. So if we go back to background and history on how the Institute started and what were some of the founding principles that Dr. Kelman referenced in the video, one of the things that stuck out to me is that he talked about that he wanted to be involved in the construction and development of new sites, so putting them in places where people needed care the most. But he also talked about training family physicians on this model of care. And so my question kind of goes to that. When I look at the your employees or the people who work with you, have your family physicians and other providers gone through some kind of training? Were they just recruited and said once they come in there's some kind of training? How does that go?
So I can actually start to answer some of those pieces, and Christina, feel free to jump in here. So the Institute was founded by Dr. Kalman, a nurse practitioner, a family nurse practitioner who still actually works with the organization since 1983, and two other family practice providers. And so one of the interesting things is that over the years as we've grown, we really have worked with the communities to develop new sites and really waiting for the community to come to us. But one of the large pieces is that education is part of our mission. So we train providers of all disciplines, but particularly we have several family practice residency programs, one in our upstate, more rural region, and then the others in our New York City practices. And they are community-based. Two of them actually are community-based family practice residency programs. And so we have really taken an active role in training primary care family practice providers to really work in a team model to be able to practice in the way that, Christina described, where you're part of a team, where there is really a lot of collaboration with other disciplines, diabetes educators and social workers and case managers and care managers and nursing. And so I think that's really the model that we've built, and that we really feel very strongly about training the next generation of providers to carry on. And for providers coming in from outside the organization, I think we attract providers who really want to practice in the communities we serve, and in the model that we, of care that we really strive to have and to deliver. So Christine, I don't know if you want to add.
I absolutely agree. What I would add as well is that when we really intensified our diabetes program efforts about 6 years ago, we knew that we needed to incorporate an ongoing, what we called in-servicing/training effort, because we were promoting this integrated team approach. And so traditionally, patients with diabetes get most of their care, and the research has shown most of their diabetes care in primary care. And so when we started our program about 6 years ago, we found that a lot of our providers, yes, they were providing diabetes care, but maybe they were not well aware of what the standards of diabetes care, medical care were, or maybe they weren't intensifying medications as aggressively as they could be. And so what we did is we started a campaign to explain why diabetes care and primary care was so important. And the way we provided training and support was we went to staff meetings, we went to provider meetings, we went to nursing meetings. And the Institute is such that we really try to foster whatever new we're trying to implement by communicating with staff via, whether it's electronically or with in-person trainings, so that people can actually start utilizing whatever new tools we've put forth. And so when we were trying to put together this new program, we really needed to do a lot of legwork to orient providers and the care team that we were trying to put together about how this could help providers provide better care. That if they had a 15-minute visit, the expectation wasn't that the provider was going to do all of these things, plus address the patient's back pain and etc., in a realistic way if they weren't using other members of their team. And we've learned that not only with diabetes, but with a lot of the work that we do, we really need to leverage the efforts of our nursing staff and our psychosocial services staff so that we can provide better care to our patients. And so there are all kinds of trainings that go on regularly in addition to the training that goes on within and among our residency programs.
You brought up a really good point, Christina, in this new system of care. One of the things that Dr. Kelman talked about is he referenced traditional health care and how a profound statement. Nobody believes in supplying everything equally to everyone. Like, that's just not the model of care, particularly for people who are what I call disenfranchised, or the ones who need it the most. And so not only is it an idea of re-educating providers and those of us who extend care, but also re-educating patients in what to expect and then how to operate in that kind of system. So can you guys, or one of you, elaborate a little bit more about how that's going and how that has worked, and whether or not patients have really are they resistant to it? Do they comply? Do they love it? What goes on? What's that like?
So I think I'll start, and then Christina. I think there's a couple of pieces. So, one of the re-education is around emergency room use, and really trying to have patients come in and utilize the primary care services and get, instead of getting some of the care, in the emergency room. So we've had a re-education around that. And in order to address some of those issues and to really create more access, we extended hours. And so we are, open till 10 p.m. and our sites were open 365 days a year. And so, whenever you create access, of course you have some changes in staffing and some difficulties that go around making an organizational decision around that. But I think that's been very helpful for patients, knowing that there, is somebody available to them that has their record, that has all their information, even though it may not be the team of people that they see, during the day, if should they come in evening hours. And one of the other interesting pieces is that we have had some discussions with patients, because now when a patient comes in, they could see the nurse, they might see the social worker, they might see a case manager, a diabetes educator. And so people were saying, I come here and I'm here for quite a period of time and I see a lot of people. And so we've really had some internal discussions about, trying to manage the flow with patients, and to try to figure out how to provide all those services in a way that works, and almost and think of it as like a buffet of services, and allow the patients to, to figure out what they need and when they need it. And so we've had a lot of those internal discussions, but yet still wanting to make sure that, everybody gets the care and gets to see the people that they need to see when they come into the centers. And so Christina can probably elaborate, but those are some of the, initial thoughts.
I completely agree. I think for the term we're using, re-education, yes, I mean, when I started here almost 6 years ago, patients were like, what is a diabetes educator? And what is it that you do? And once they have experience with you or with the team and how you've helped them better understand something, then they seek you again. And so there definitely is a period of the patient understanding, why am I talking to you and not my primary care doctor? But once they see that you're communicating with their doctor and that you have access to their doctor, they're very open and welcoming. I think this brings to issue a bigger topic that is not the focus of this presentation, but health literacy. And so health literacy really starts with trying to gauge what the patient needs and what the patient wants and what they already understand, and then if they're an adult learner, you're leveraging what they have used to survive in life to kind of say, hey, it's those same principles. Now let's use them to better your care. And so I think it's been amazing to see this process and this turnaround. But yeah, there are patients that say, hey, like, I know what you do, but I came here to see my doctor. I really don't want to stay here, 2 hours today. But then we have, like Verna says, a buffet of services. And so maybe they can self-select to come to one of our groups. And so what we're finding is that for chronic illnesses like diabetes and things like obesity, we want patients to engage more regularly at their own volition, and come to our groups. And so what we're starting to do is give patients the opportunity to seek out peer support and to seek out more education by offering more groups that are at times that are convenient to them to address the things that are important to them. And I think that's kind of the phase and the area that's of most interest to me, because I think that has a lot of power in patients really taking ownership of their health.
Well, I think people always have choices, and so certainly our centers are in communities that are traditionally underserved, and so what we've tried to do is we've paid a lot of attention to facilities and trying to put nice facilities that are very patient-centered in the communities that we serve. We've tried to really build spaces so that we can have groups. We've tried to put community rooms in so that community organizations, we can have training and teaching sessions. And so I think our philosophy is that a community health center really should be a part of the community and interact with the community. And so one of the things I think we get from that is that we do get patients who hear about us through some of these other activities. We've also been very active in some community-based activities, reach around heart disease and diabetes, where we've really partnered with local churches and other organizations. And so I think all of those pieces have been integral in terms of building our centers. I also think just visibility in the community where we are and having the extended hours and really being available to patients. And we have tried some other initiatives. We're certainly always developing our technology and having kiosks in our front area so that patients can come in and register and do all of those check-in sort of administrative pieces on the kiosk and not have to wait in line or come in and change an appointment. We've also tried to put some health information kiosks in our centers so that patients can come in. And we've also done a lot of thinking about, concierge sort of primary care and really thinking, well, if you don't want patients to wait, then you don't have waiting rooms, but how do you really manage that workflow? And trying to use point of care rooms that are available to all different providers. And so there certainly are some things that we're trying to think through and work on as we go forward.
Christina, did you have something to add before I ask the next question?
I do not.
Okay. I wanted to explore a little bit more about the community aspect. I think one of you mentioned a fascinating scenario, which I would just love to hear more about. A food bank being able to access items in the medical record of a patient who's being serviced. Now, how exactly does that work? Like, how, for one, what technology is available at the food bank, and then what kinds of permissions, what is the patient told? Just how does that process work in the scenario with the food bank, for instance?
So we have developed a physician, most electronic health records have physician portal functionality, and so we have what we call Institute Link, which is the physician portal for our electronic health record, which happens to be Epic. And what we've done is worked with community-based organizations to utilize that physician portal and have access so they can speak with the patient that we have in common, obtain consent, which is kept in that within that organization, and then they will have access to the electronic health record for that patient. They can also register a new patient in the system and gain consent. They're able to then go in, they're able to schedule appointments, they're able to change appointments, they're able to communicate with that patient's provider of any discipline. They're able to have access to some information about maybe they referred somebody to see if they kept an appointment and, maybe to look at medications or diagnoses to be able to care for that patient. So we do have quite a few organizations that access, and particularly our patients with diabetes. Many times it's helpful because if they're going into another service or community-based organization, maybe admitted to a substance abuse program or getting services like we talked about from a food pantry or in a foster home or a mental health home, they can actually go in and see the information. Oh, I see you have diabetes. Let's talk to your provider about what we might need to do differently, or, have you been in? Maybe we need to make an appointment. And so what it really does is involve the community and really try to express to the patients that there's a team of people both in the health center and outside the health center that are really working with you and here to support you and help, care for you and your diabetes. And so I think it's been really helpful. It's also able to provide some continuity so that if somebody does go into a program that has access to our physician portal, they can say, oh, okay, you forgot to mention that you had diabetes. What we need to do is try to figure this out. I can see what medications you're on, and then they're able to continue the medications or communicate with the primary care provider. And so it's been really instrumental in the care for our diabetes patients.
And does it just so happen that your patients end up in places where you already have partnerships, or have you just, how does that really work practically? How would one of your patients just happen to end up in that food pantry? Is that a referral that takes place? And how did you form that community partnership?
So generally, we have close ties with the community, and we try to really make sure that the services that we don't provide in-house, that there's other organizations in the community who do it and do it well. So we really try to connect with them. So we'll, meet with the organization. We'll talk about services that each organization provides, and we'll, many people sort of know it like an MOU or, some sort of a memorandum saying that you'll exchange referrals. And then what we do is we actually give them information on Institute Link. We give them a training session that can happen over, via a web-based training. As long as they have the internet, then they're able to access the portal. And most organizations, even your smallest community-based organizations, have, a computer or something in their offices that they're able to use to get on the internet to access Institute Link. And then what we really do is we try to do the referrals electronically so we can notify them, and they can notify us if they're sending information. We also use it, they can also upload documents. So if somebody was being discharged from a program, or if a menu was designed at a community food pantry, for example, they could upload that so that it would be available to Christina and her team at the practice. So we're going to really continue to try to develop, more organizations to participate and be able to really, one of our hopes is that there will someday be a shared care plan that the outside organizations and the patient will be able to document, and it'll be like a living plan. And so that's something, if we were going to have a wish list over the next couple of years, I can see us developing that technology and functionality.
Speak to people that are in our audience and they are not where you are, but definitely their interest is piqued and they want to do a better job of engaging the community. So for a person that's out there, what would be your top 5 partnerships that you would say a community health center or even a provider, what are your top 5 community partnerships would they need to work on developing?
I don't know, Christina, if you want to talk in terms of, the diabetic patients, because just so much work with the Bronx Reach and that. So maybe I'll let you kick off and then I'll chime in.
Sure. So as Werner had mentioned earlier, we've done significant work with one of the groups within the Institute known as Bronx Health Reach. And a lot of their work has been exactly that, in the community, establishing relationships, understanding what community residents who might already be patients of ours or may not need and want in their communities. And so we've done a lot of work around diabetes education in churches, in schools, in salons and barbershops. I think those were some of the top groups that they collaborated and worked with some of the programming that they were involved with and in. And I would say, and I would agree, a church, a school, a community center, food pantries, and related community service organizations that provide some kind of services in the community are also quite beneficial. I think those would be my top 3. A major healthcare partner, whether it's a hospital group or hospital groups, is important, and I would say that's 4. That could be 4 and 5, but I think those are the partners I think that have been the most helpful in helping us collaborate with the community that I can think of right now.
I think we've also spent a lot of time, partnering with the community-based SROs. So we do have a considerable amount of population that is a little bit transient. but really partnering with them so that they can have immediate access to primary care and mental health services, through links. So if somebody comes in late in the evening, they can make an appointment for the following day to make sure somebody gets medications or gets the care that they need, and then can, follow up. So I think the community SROs would definitely be one that I would choose. I also have an interest in trying to have continuity between people that are going in and out of correctional. We have a our population that goes in and out of some of the correctional facilities, and so the ability to really make sure that there's some continuity of care, and really working with them to try to be on link and coordinate services. And some of the larger, mental health residences and foster care homes are really good partners, and we've really worked together to try to create almost a system of care for some of the people that might have previously fallen through the cracks.
A nice segue to our audience too. I think some people are having some problems with their audio, so they're not able to hear us. We will make this video available, but to the audience, please feel free to send us your questions. I do see one that just showed up. Does IHF or any of your partners, home health agencies, use any type of home monitoring or telehealth services?
We do not have any home monitoring services or devices at this point. We do have some telemedicine equipment that we have recently dusted off a little bit, and we are redeploying to try to provide psychiatry services in some of our more remote areas.
There's a really good question about a rural community, and please clarify the question if I don't get it right. Do you have suggestions or experiences working with more rural community outreach? Does your family practice program do rural placements? So I'm not sure if you're asking about reaching out for community partnerships or particularly for providers to be recruited. So you can clarify if necessary.
So we do have practices that are outside of New York City and in the Hudson Valley region of New York. And many times people don't realize that outside of New York City, if you go, 90, 100 miles outside of New York City, there are actually some very rural, underserved communities in those parts of New York. So we do certainly, serve those communities, and it presents a whole host of different challenges, as many of you know who work in rural communities, in terms of resources and in terms of transportation. Getting people in and overcoming some of the transportation barriers is huge in some of those communities, but we certainly do an awful lot of outreach. We do have a family practice residency and some mental health training programs up in those communities that certainly bring in a lot of people from around the country who are interested in training and working in those communities. So I'm not really sure if that tried to touch on a little bit of all of that question.
In bringing up the mental health or behavior health, I think he clarified that he was speaking in terms of both. So in doing community outreach in rural areas as well as provider placements. There is another question. Well, before we transition with the behavioral health or the mental health services for your diabetes patients, I know that with many EHR systems, there are screenings or alerts that pop up. And so I'm assuming that every patient is then screened for diabetes, who has diabetes, or maybe every patient is also screened for depression. But are there any other kinds of behavioral health services that are built in? I do know that for many people who suffer from chronic illnesses, then there is a strong correlation with depression as well as anxiety and maybe other mental health issues. So how is that integrated into what you guys are doing, and then how are your providers prepared to deal with it?
So we have a very strong behavioral health program, and we have a shared record so that the information is available. As Christina mentioned, she can see all of the behavioral health notes. We have a large population of patients who have co-occurring diabetes and another significant mental illness, because the Institute has both behavioral health embedded in the primary care centers and then also some specialized mental health services. And so we really work closely with the diabetes teams for a lot of those patients who are affected with both diabetes and mental illness. So we have groups, we have collaboration between the two. We often have case conferences and work to co-manage those patients. We actually will run reports to look at patients. Recently we're looking at patients who were bipolar and depression and making sure that there were care conferences and that everybody had care plans for both diabetes and bipolar, working with providers now to develop shared care plans for those patients. So really looking to reinforce, to develop some partialized manageable goals for patients that span both medical and mental health, and then jointly reinforce them across the team of providers. So I think that we've really learned a lot over the past couple of years about how to collaborate and how to teach our providers of all disciplines to collaborate. When do they do it? How do they do it? And people like to communicate in different ways, and people may not be in centers at the same time. And so I think we've spent a lot of time figuring out how to collaborate and manage those patients. But we do have a significant number of patients that have comorbid mental health diagnoses.
Yeah, and I would just add that there's a variety of ways that we collaborate. Whether it's through using the EMR to screen patients for depression, a member of the diabetes team, whether it's a CDE or a diabetes health coach, assessing the patient for signs and symptoms of depression. We're fortunate in many of our sites to have on-site available social workers and case managers, and so we often don't have to wait very long for an answer or for assistance or support, in addition to using the EMR. And I think in addition to that, we have collaborated in different ways via groups and patient education groups to have social work and diabetes educator collaborate in facilitating groups. And at some sites, what we do, if we know that we are going to get, we plan for something called diabetes days, where the patient sees either the primary care provider, a member of the diabetes team, and or a member of the psychosocial services department. And we purposely schedule those patients on that day so that we can give them the array of services that they are likely to need after having done some chart review.
I realized too that I didn't necessarily answer the screening question. So we do screen all of our patients 12 and up with the PHQ for depression. We also have about 60 behavioral health screening tools built into the EHR at this point. Not that we screen all patients with all of them, but we do routinely screen for depression and anxiety. And then, as we go forward, the tools are available to any discipline who's seeing that patient to screen them for any other mental health diagnoses that they think may be a possibility.
And Christina, this is probably a question for you. Do you use dedicated diabetes educators or general team staff to provide diabetes education?
So we actually are fortunate to have dedicated diabetes educators. We have 7, including myself, who's a Jane of many trades. We have health coaches, which are not clinicians. They're not CDEs, but they provide diabetes education, basic diabetes education, assessment, and support. They also are the ones that manage the registry at each site. And we're fortunate enough to get every year AmeriCorps Health Corps members who do a lot of the group facilitation that we are able to offer annually with support from a member of the diabetes team. And so we meet very regularly as a group of about 17 or 18 to strategize what we want to do at our sites. And then we also provide training to the new members that come to our team every year so that they can quickly start doing groups. And this is not unique to our diabetes program, but generally how we use and how we train new professionals so that they can actually get their hands dirty with helping us provide support and care to patients in our clinics.
Mhm.
Gotcha. We're coming up on, I want us to take a break and show a commercial that we've prepared for you. But before we do, I did have another question. When we come back from the break, I'd like for us to kind of switch gears and talk a little bit about the data and how the data is driving changes and improvements. But before we do, just a question about your care teams. So on a typical day, when your providers come to work, when your staff comes to work, is there like a morning huddle where you all get together? Is that done
Mhm.
on teams within each community health center? How does that work, and how are people? So in the morning, is everyone updated on who's on the schedule that day, or just a little bit about how it goes on a day?
So it works a little bit different in different practices because obviously you have some smaller, larger teaching practices. So in our larger, particularly in our larger teaching practices, we've divided people up into teams, and everybody has buttons now with a color, and they're assigned, to a team of that particular color, which does huddle in the morning. Some of them huddle also in the afternoon because we go into the evening hours, and that would be, the primary care providers, residents, nursing, a diabetes educator, case manager, a social worker. Those are sort of some, traditional people that would be in that morning huddle. And in some of the other sites, it would be a huddle of just the team members. And Christina can sort of talk about her staff's involvement in some of the morning huddles.
So I think at the larger sites where there is, a full array of diabetes team members, they'll participate. There might be even an evening huddle at the sites that have extended hours. And so if we're trying to reach our quality threshold for monofilament because we're not meeting that measure, that's often a good time to talk at the huddle to say, hey, great job. We went up a certain percentage from last week to this week or last month to this month, but I'm noticing, we really need to do a better job when patients come in to encourage them to take off their shoes. And so it might be something general like that, or it might be, hey doctor or hey nurse such and such, this patient's coming in, let's work together to make sure that, they don't leave without making sure that they have, a refill for their insulin. And so huddles are very instrumental at sites that don't have, the luxury of having a member, many other healthcare or team members. Might just be a provider, an LPN, and a MOA, medical office assistant. They can then, send us a message electronically. We saw this patient in the clinic today. Can a member of your team outreach? And that also works very well.
Thank you very much. I think you guys that are behind the scenes can roll that commercial now.
Hello and welcome to the Partnership for Diabetes Health Equity website. This is a partnership between Morehouse School of Medicine and the Bristol-Myer Squibb Foundation. I'm going to focus only on our Learn, Share, and Connect element model in this video, and we're going to start with best practices in our main menu. We have 4 categories available: clinical, community, health outcomes, and tying it all together. And if we click on one of these categories, it will take us to a timeline that will populate with stories for sites where champions are doing great things in the community. Here's our champion. We can see a video, download tools and templates, and also link back to other best practice stories. But most of all, if we click on this image, we'll go to a PowerPoint presentation that loads in the cloud. There's nothing to download or anything to do, and we can see the PowerPoint presentation that gives us information about the site in its entirety. We can also close this tab and still have our site available to us. Next, let's talk about our share element, in which we have resources available to you, tools and templates that can be downloaded, as well as other resources from CDC and PubMed. We can go to tools and templates and see categories available, in which you can click on any of these categories and go to a page where documents are available to you to download, and these are free to the public. If we talk about our learn element, we can go to our training page where we have webinars, PDFs, and other videos available to you in timeline form, where you can look at these and view these 24 hours a day, 7 days a week at your leisure. We also have our connect element where we have a form available to you, again, available to the public to be able to read 24 hours a day, 7 days a week. However, you must be a member in order to post a topic or comment on a topic that has already been posted. So you can do that by going to our login register button in the top right corner, and you can register for free. And then once you're a member, you can log in and go to the form at the bottom, put in your topic, what your message or your question is, and hit submit, and your topic will be posted to the forum. Thank you and have a wonderful day. Enjoy the site.
Thank you. So as we transition, one of the questions, one of the things that we want to bring out, as I mentioned in the beginning, we are focusing on this 3-element model, and we've talked about the clinic and things that are taking place there. We talked about the community, but let's now transition to the data. And I just wanted to see if you guys could take a moment to share with us how data is driving what you do when you, what you're collecting, and how does that impact the changes that you make, and then how quickly do those changes take place?
So Christina, why don't you go ahead?
Sure. I think that that's a challenging question. It's a challenging topic. I think it's a topic that many of us are trying to figure out how to best use. Data is so important, but you can also get inundated with data and not know how to proceed with the data that's before you. And so I think the great thing about data is it doesn't lie. And so if you look at the data and it something doesn't look right, you could probably go back and rerun the data and see if there was something wrong with your criteria, etc. It also allows you to really know who your population is across a group of patients, and it also allows you to make decisions about how to optimize the services and the personnel that you have. And so we're fortunate to have a fairly large team, but you know, others that are listening to this webinar might be a smaller practice and not know where to start. And so I think data allows you to figure out, okay, this is who our patients are, this is where they are with their numbers, and this is where we need to be. And so then you can make decisions about what kinds of services you can provide patients based on that. I think data is super important to measuring how well you're doing in providing good care. It's two-dimensional, so it doesn't share the patient story or the challenges the patient is having, but it allows you to measure over time, have we improved in the expected care that we should be providing these patients? And so I proudly say that we can say that, but I also know that when I look at the data, sometimes I get very nervous because I'm like, oh wow, we were doing so great in this area, why haven't we moved? Or there are certain metrics, and I'm speaking, I know, very broadly, that just are so challenging to move, and that's our ophthalmology metric. And continuing to figure out why hasn't this moved more. And so it allows for more structured discussion. It allows for more critical thinking about how you use your personnel and your resources. And it also allows for assessment of your providers and your site to see how well they're doing with the rest of your group, or with the rest of the nation, or with the rest of the state. And so I think we definitely use data to measure ourselves against our fellow colleagues within the Institute, against what the national standards are, and also providers to manage their panels of patients and say, hey, my panel compared to my colleague's panel, I mean, I can do better. And so some of that self-assessment also happens. Is it challenging? Absolutely, if you don't devote time to discussion around the data and how you want your staff to use data. So that's what I mean by it's really challenging, because you just can't give someone a sheet and say, hey, do something with this.
I think we've spent a lot of time organizationally trying to figure this out, and the use of data sort of has to permeate through all of your processes. And so we've really tried to define. So we started with the diabetes registry as being like the primary source of information for our providers around the care and the panel of their diabetes patients. And now, we're able to get reports from the electronic health record where they're able to run with their patients who haven't been in, who are diabetic, who have, levels. They're able to send letters or just send notifications to the patient portal. We now have a feature where they can actually look and see patients coming in their schedule, who are uncontrolled or who might need some extra care. That's actually being rolled out this coming week so that they'll be able to really pull that up and see all of the metrics across the board. I think we also have spent some time looking at the data and then using that to guide the decision supports that we put in the system. You don't want to have, flood providers with decision supports, and so we tend to sometimes put them in or take them out depending on what the data may tell us. And then, to look at the data and say, is this something we need to do an education around, or can we put a decision support in, or both? Is this something that we feel strongly enough so that it could potentially be a hard stop and you can't, go forward? And then also saying, okay, now that we have this data and we're going to be looking at this data across the organization as a whole, by site, by provider, what are we going to do with it and how are we going to weave that? So is it going to be tied into our incentive process? Is it going to be, reflected in our provider evaluations? And if so, what data and how? And so we have now moved, forward and really started to build evaluations that are dependent on, doing well in some of the metrics. So I think you have to think it through, organizationally and across all of your processes. And how do you let providers know, as they're coming in, that this is something that you watch, and how you use data, and how do you, train residents to use data to drive their practice and to be able to teach them how to manage their panels, and to use data to be able to be more efficient in doing that. So I think it's been the subject of a lot of discussion, and, we're continuing to learn as we go along.
I did have a follow-up question. I know one of the things that's necessary in practice transformation and care coordination is empowering people to be leaders. So making people who may have traditionally had a position that was not in leadership, making them over a project or whatever. So when it comes to managing data, who's responsible for producing the reports? Who's responsible for creating the solution, communicating it to the staff? Is it different leadership levels? Is it one person? Who's the go-to that's the data guru?
So I think some of the data is, developed organizationally, but a lot of the data now providers actually have access to, and they will run it, or teams will run it. There's some data that we make available, and it really depends on practice. So it isn't necessarily the physician or the medical director who might, be responsible for some of this. It's really going to be somebody on the team who has some leadership skills and who, steps up and maybe runs the morning huddles or the afternoon huddles and, brings these patients. I think it really varies across our system. I think that, the providers now are really learning to get this information and to use it to make decisions, and then trying to figure out, okay, who on my team can really be the go-to person, to help me manage this information. So I say that it varies, and I do say that we really do look for, people with the leadership qualities, maybe not necessarily in management positions, who can help us do this work and who often become instrumental in some of this practice transformation work. They become internal champions around particular issues and really take it on and then develop. I mean, one of the reasons that Christina is where she is in the organization is because she did have those qualities, and she, took ownership and then sort of developed and took a leadership role in her practice, and then, spanned across the organization. And so I think that's really something that we hold to heart in terms of our own growth and development of our staff.
Thank you very much.
I'd also,
I was going to say my window was frozen for a second, so go ahead, Christina.
I'd also add that I think, the lesson learned is that if you keep giving people that already have a lot of work more work, they may not be the best ones to give ownership of this data, this data management. And so it often is someone who has excelled or has demonstrated ability or strength in fulfilling a project, and then providing support so that they can continue to do that. I mean, actually at our sites, what we do is a member of the diabetes team, calls through the diabetes data, promotes what it is that we're doing at the site at a staff meeting, and then works individually with providers. And so that there's this ongoing dialogue, that there's a component that she calls, and then at some point what she gives to the provider is something more tangible and more easy to use than just a list of 150 patients.
Okay. Well, we are nearing time for us to end. Before I give our final announcements, I just want to ask you, Dr. Little or Christina, if you have any closing thoughts. And one of the ways I thought we could frame it is if you were to think about what you do that's valuable there that makes a difference. What is the one thing that you do on a day in or day out basis that makes a difference that you're most proud of?
Christina,
I think that's
think about it.
I think my response is going to be a little cheesy and cliche, but I think it's communication and not using traditional means of communication, being creative and innovative with how you communicate with people, and what message you're trying to communicate. And I'm a firm believer of the positive sandwich, meaning that you want to tell people what they're doing well before you saturate with them with what needs to be improved, and say, hey, because of our good efforts, we can do this, versus, ending things on a sour note. And so I really feel it's communication and the execution of that communication.
I would have to say it's really being mission driven and keeping front and center what the mission is to really bring, quality care to people who need it, every day, all day. And trying to figure out a better way to do that, really being committed to trying to figure out a better way to do that every day. And I think that's one thing I can really say about the Institute as an organization. We're always changing because we have, a group of people and providers who are saying, how can we do this better? And we say it every day. And so that means that we're continually changing how we do things, which makes for sometimes a very difficult environment because it is always changing. But on the other hand, I think there's a lot of satisfaction that comes out to know that you're really trying to do a better job.
Okay, thank you both for not only sharing that, but for spending this hour with us, just discussing and allowing us to peel back a layer and step inside the great work that you guys are doing at the Institute for Family Health. To our audience, thank you so much for taking a moment out of your busy day to spend this time with us. I want to remind you that we here at diabeteshealthequity.org, it is our intention to be your online diabetes health equity resource center and virtual community. This three-day event was done solely to allow you to see what we have to offer and to begin to think about how you want to get involved. So we like to connect with you. You can go onto the website and post a comment on the forum. You can read a best practice story, download tools and templates. And this is most important. If you know of a best practice story around this space that we should know about, or a health equity champion that you want to share with us, then please email us at info@diabeteshealthequity.org. You can tweet us at PFORDHE, that's P4DHE, at the hashtag PDHE, or you can like us on Facebook. We are looking for best practice stories. We're looking for people who'd like to do webinars. We're going to be hosting what we call coffee shop chats, which will occur once or twice a month. And it'll be an informal conversation with a real world expert so that you and the audience can come and just spend some time picking the brain of someone who's doing what you like to learn to do. So again, thank you so much to our distinguished guests on our panel today, and to you in the audience. I'd like to give a special shout out to our IT staff, those guys who are behind the scenes making this happen. Thank you guys for your participation today. Again, I'd just like to remind you that this project is made possible through the partnership with Morehouse School of Medicine and the Bristol-Myer Squibb Foundation Together on Diabetes initiative. Thank you again and have a wonderful rest of your afternoon.
Thank you.
Thank you.